webinar of the Virtual Medical Consilium on tuberculosis, supported by WHO Europe. I am Dr. Elmira Gurbanova, coordinator of the Virtual Medical Consilium. Today is International Children's Day, and also just recently WHO published a comprehensive guideline on tuberculosis in children. So we decided to devote the topic of today's webinar to TB in children. Today we'll have a unique opportunity to hear presentation and to hear about all the new developments on tuberculosis in children from the experts who were closely involved into this in the development of this guideline. So I invite all of you to use this opportunity to ask questions, if any. And just shortly about the logistics and about the structure of our webinar. Our webinar this time is on English with simultaneous translation to Russian. So please choose the language which is comfortable for you on the panel. The materials of this webinar are available following the link, which you may see in the chat. We will add the Russian translation of presentation in several days after the webinar. As a last point, I would like to ask you to keep your microphones muted. And during the webinar, you may write your questions in the chat, and you're very welcome to write your questions in the chat. And we have a session of questions and answers at the end of the webinar, where we are going to read all the questions and discuss and have a discussion with presenters. But if for some reasons we will not be able to answer to all questions during the half an hour for which is the webinar planned, then we will answer you in written and circulate among all participants of today's webinar. Thank you so much for joining once again, and it's my pleasure to give the word to Dr. Askar Yedilbayev from WHO Europe for the welcoming remarks. Dr. Yedilbayev, the floor is yours.
Уважаемая Эльмира, спасибо большое.
Dear Elmira, dear colleagues, dear participants of the 16th webinar of the European Virtual Medical Consilium, we are very glad to welcome
Европейского регионального бюро ВОЗ.
On behalf of WHO Europe, and we would like to wish you all the best. And today's topic is dedicated to one of the most pertinent issues of TB management in children and adolescents. As Elmira has mentioned, we've dedicated this topic to the call because of the International Children's Day we celebrate today. And as you all know, quite recently, new module of the consolidated WHO guidelines was published on TB in children and adolescents. And within regionalization work, and in order to transition to these new guidelines, we have organized today's call, and we have split it into two parts. The second part will be presented closer to the end of June. Therefore, we'd like to thank our colleagues from the Global TB Program of the headquarters in Geneva for participation. And I would like to thank in advance all the presenters who will cover the topic and who will present the latest developments and recommendations in this area. Thank you very much, and I wish you very fruitful work at the webinar.
Thank you so much, Askar. And it's my honor to give the floor to Dr. Kerri, Viney, and Dr. Annemieke from WHO Global Tuberculosis Program, WHO headquarters, to speak on today's topic. Please, the floor is yours.
Thank you so much, Elmira and Askar, and a warm good morning or beginning of the afternoon to all of you. Just a minor correction, I'm not a doctor, so I have a background in public health. So greetings from Geneva, and thank you so much for this invitation to present. During this first session, the slides are not moving. Yes, during this first session, we will touch upon the burden of TB in children and adolescents, introduce the 2022 WHO guidelines on the management of TB in children and adolescents, and then focus on TB screening and contact investigation, prevention of tuberculosis, and the new guidance on diagnostic approaches in children and adolescents. So first, 2 slides on the burden of TB in children and adolescents, and it's the global burden. The estimated incidence of TB in children and young adolescents under 15 years of age is just under 1.1 million, and therefore they make up about 11% of the total incidence of just below 10 million cases per year. Overall death increased for the first time to 1.5 million in 2020 as a result of the impact of the COVID pandemic. Mortality has been estimated at 226,000 in children and young adolescents under 15 years of age, which means that they make up 15% of all TB deaths, whereas they constitute 11% of the overall TB burden. The overall case detection gap has widened in 2020. Case detection for all TB was 36.5% in children under 15 years of age, but only 27.5% in children under 5 years. Almost 2/3 of eligible children under 5 years do not receive TB preventive treatment, and therefore run the risk of getting sick with TB. Now, moving to an introduction on the new products. WHO held a guideline development group meeting in May and June 2021, now almost 1 year ago. The guideline development group reviewed evidence on a wide range of PICO questions, covering diagnostic approaches, treatment of drug-susceptible TB, TB meningitis, and drug-resistant TB, as well as models of care. A rapid communication was published in August 2021 to flag the upcoming changes. And in March this year, on the occasion of World TB Day, the full guidelines were published, along with an operational handbook, which provides practical implementation guidance on the full cascade of care. The links to both documents are at the bottom of this slide. The target audience for both documents includes national TB programs, but also national programs on HIV, primary healthcare, and mother and child health, as well as health workers at various levels, the education sector, and various organizations involved in TB care for children and adolescents. The objective is to contribute to reductions in TB-related morbidity and mortality in this age group, in line with the global targets in the Sustainable Development Goals, the NTB strategy, and the UN General Assembly high-level meeting on the fight against TB. The analytic framework used in the pathway of TB infection and disease, the analytic framework is the pathway of TB infection and disease in an individual child or adolescent, and the interface with or the retention across sequential stages of care, also called the cascade of care, which is shown in the figure on the right. This includes multiple steps from exposure to TB infection and possibly progression to TB disease. Each step in the cascade of care requires evidence-based interventions to reduce TB transmission, prevent TB, enable early and accurate diagnosis of TB, and optimize treatment outcomes for children with drug-susceptible or drug-resistant TB. Child, adolescent, and family-friendly services are needed to optimize access to high quality of care. The operational handbook contains additional information on how to practically implement the new and existing recommendations relevant to children and adolescents. It includes information on TB screening, contact investigation, TB preventive treatment, and other TB preventive measures, diagnostic approaches, treatment and models of care, and special situations such as the management of TB in children living with HIV, the management of TB during pregnancy and in the newborn, and the management of children with severe acute malnutrition or severe pneumonia. It also addresses palliative care. It also contains treatment decision algorithms and other implementation tools, such as updated second-line dosing tables, a dosing table for the new TB and meningitis regimen, and advice on how to administer a TST, information on sample collection procedures, and much more. The consolidated guidelines bring together valid recommendations from other WHO guidelines with relevance to these age groups, in addition to the new recommendations. This slide provides an overview of the different guidelines from which relevant recommendations were sourced, including TB prevention and screening guidelines, the BCG position paper, guidelines on rapid diagnostics, and treatment of drug-resistant and drug-susceptible TB. Some validated recommendations from the 2014 childhood TB guidelines as well as HIV and nutrition guidelines. All guidelines and recommendations, along with operational handbooks and training materials, are in the process of being featured on the WHO TB knowledge sharing platform, of which the link is shown on this slide. I will now move on to talk a little bit more about TB screening and contact investigation. TB screening and contact investigation are the first steps of the cascade of care. Screening serves to identify people, including children and adolescents, who may have TB disease, so presumptive TB, and who need further evaluation to make or confirm a TB diagnosis. It also helps to identify people, including children and adolescents, who are eligible for and who could benefit from TB preventive treatment. Systematic screening is conducted in a predetermined target group at risk of TB disease. It aims to detect TB disease early, minimize delays in treatment initiation, and thereby in reducing health sequelae for the patient, ongoing transmission in the community, and adverse social and economic consequences of TB for individuals and their families. Contact investigation is the systematic identification of people, including children and adolescents, with previously undiagnosed TB disease and TB infection among the contacts of a person with TB. Household contacts of people with pulmonary TB, including children and adolescents, are a well-recognized risk group for TB infection and TB disease, including prevalent TB detected at the time of initial contact investigation and incident TB that occurs within the subsequent 2 to 5 years. WHO therefore strongly recommends that household contacts and other close contacts of people with pulmonary TB are systematically screened for TB disease. The risk of TB infection is greatest if exposure to a person with TB disease is close and prolonged. For example, the exposure of an infant or toddler to the mother or another caregiver in the household. Younger children, especially those aged under 2 years, are at particular high risk of TB progression after infection. And considering that 80% of pediatric deaths from TB occur in children under 5 years of age, earlier diagnosis of adults with infectious TB and timely screening, diagnosis and treatment of children who are contacts are important approaches to reduce TB disease and death in this age group. Children and adolescents living with HIV are also at an increased risk of progression from TB infection to TB disease. A child living with HIV is 3.5 times more likely to progress to TB disease than a child who is HIV negative. The risk remains elevated in children on antiretroviral therapy. WHO strongly recommends that children and young adolescents below 15 years of age who are close contacts of a person with TB and all children and adolescents living with HIV are systematically screened for TB. Contact investigation should be a standard component of national TB programs. It can be conducted using a facility-based or a community-based model. Community-based models are usually more people-centered, closer to where people live, but a mixed model may be needed when resources are limited or when communities are not comfortable with household visits. Successful contact investigation depends on the availability of adequate resources and dedicated human resources, coordination between actors at the community and facility levels, with clearly defined roles for both TB nurses or focal points at the facility level and for community health workers, initial and refresher trainings on contact investigation and provision of TB preventive treatment, regular on-site coaching and sharing of experiences, diagnosis and dispensing of medicines at health facilities, provision of appropriate monitoring tools, including for listing of contacts and TPT cards to monitor treatment adherence and completion, reimbursement of transport costs, and so on. It is very important to point out that people with TB should never be compelled to disclose contacts or help ensure completion of contact investigation. Due diligence is necessary to safeguard the privacy, confidentiality, and human rights of all people involved in contact investigation and to avoid stigma and discrimination. Screening approaches differ slightly for children and young adolescents, so those below 15 years, who are close contacts of a person with TB, and for children living with HIV, as compared to screening approaches for high-risk groups and general population in high TB burden settings for all individuals aged 15 years and older. Among children and young adolescents below 15 years who are close contacts of a person with TB, WHO recommends the use of symptom screen. So anyone of cough more than 2 weeks, fever for more than 2 weeks, or poor weight gain or weight loss in the last 3 months, or chest X-ray, or a combination of both. In young children, reduced playfulness or lethargy should also be included, since prolonged cough may be absent in children with disseminated disease. For children below 10 years living with HIV, WHO recommends the use of a symptom-based screening, including anyone of current cough, fever, poor weight gain, or close contact with a person who has TB. The operational handbook on pages 90 to 24 contains various algorithms to screen children and young adolescents below 15 years of age who are close or household contacts. An algorithm for TB screening in children with symptoms, and if one or more of the symptoms is present, the child or young adolescent is regarded as having a positive screen and should be managed as having presumptive TB. It's useful to examine the child growth chart regularly, and symptom screen alone has a low specificity. However, the risk of a missed TB diagnosis is generally judged to outweigh the risk of a false diagnosis and unnecessary TB treatment, especially as children generally tolerate TB treatment and TB preventive treatment well. Then there is an algorithm for TB screening of children with chest X-ray. Accuracy of chest X-ray is not disaggregated by age group, and chest X-ray findings in young and older children may lead to important differences in sensitivity and specificity by age group. TB in younger children may be subtle and hard to see if the quality of chest X-ray is not optimal. When using chest X-ray in younger children, ideally both posterior and anterior and lateral views are done. The operational handbook also contains screening algorithms for parallel TB screening with symptoms and chest X-ray, and an algorithm for sequential positive serial TB screening and sequential negative serial TB screening. Molecular WHO recommended rapid tests are not currently recommended for screening for TB disease in children and young adolescents below 15 years of age, but they should be used to diagnose TB disease in children who screen positive using a symptom screen or chest X-ray. Tests for TB infection provide a marker of TB infection. However, as in adults, TST and IGRA should not be used to screen for TB disease in children, as these tests cannot distinguish TB infection from TB disease and cannot predict who will progress to TB disease. Children living with HIV under 10 years of age should be screened for TB at every encounter with a healthcare worker for current cough, fever, poor weight gain, or close contact with a person with TB. Children who screen positive on any of these symptoms should undergo further diagnostic evaluation for TB disease. Screening for TB can be difficult in a child or adolescent living with HIV, as they may have extrapulmonary TB disease or atypical symptoms. Healthcare workers should therefore maintain a high clinical suspicion of TB in any child living with HIV, even in the absence of classic symptoms of TB, especially in high TB burden areas or settings. Adolescents living with HIV, so those aged 10 to 19 years of age, should be screened in the same way as adults, using single screening algorithms, including the 4-symptom screen, including cough, fever, weight loss, or night sweats, and checking for other diseases, C-reactive protein, chest X-ray or molecular WHO recommended rapid diagnostic tests. Algorithms are also available for a combination of the 4-symptom screen and C-reactive protein, as well as for the 4-symptom screen and chest X-ray. Moving on to TB prevention, which is covered in Chapter 3 of the Operational Handbook. TB is preventable, but it continues to impact the lives and development of millions of children and adolescents. It is estimated that 7.5 million children and young adolescents are infected with tuberculosis each year. People infected with TB are neither sick nor contagious, but at a greater risk of developing TB disease, especially those with a weakened immunity. Hence the importance of preventive measures. Young children, especially those below 2 years of age, are at an increased risk of progressing to TB disease and developing severe forms of TB disease, including disseminated TB or TB meningitis, with increased risks of lifelong sequelae or death. WHO strongly recommends TB prevention and has developed policy recommendations related to BCG vaccination, infection control, as well as the provision of TB preventive treatment. Today in this presentation, we will focus on the testing for TB infection and the provision of TB preventive treatment. Tuberculosis preventive treatment is effective in reducing progression from TB infection to disease. Its effectiveness ranges from 60% to 90%, and protection can last for many years. There are two broad at-risk child and adolescent populations that need systematic assessment for eligibility for TPT. The first, children and adolescents with an elevated risk of progression from TB infection to TB disease, including children and adolescents living with HIV, and adolescents with specific comorbidities or on specific treatment, including anti-tumor necrosis factor treatment, dialysis, preparing for an organ or hematological transplantation. And the second group, children and adolescents with increased likelihood of exposure to TB, including household contact of people with bacteriologically confirmed TB, and those living or working in institutional or crowded settings for older adolescents. Recent immigrants for high TB burden countries, homeless people, people who use drugs are of course also at an increased risk. It is important to exclude TB disease before initiating TB preventive treatment. WHO recommends the use of a clinical algorithm based on screening for symptoms of TB, history of contact with a person with TB, HIV status, age, TB infection, test results, and abnormal findings on chest X-ray. An algorithm for TB infection testing and TB preventive treatment in children and adolescents is included on page 38 of the operational handbook. TST and IGRA can be used to test for TB infection. It should be noted that people living with HIV who are on ART benefit from TPT regardless of whether they test positive or negative for TB infection. WHO recommends that testing for TB infection should not be a requirement for initiating TB among people living with HIV and child contacts aged below 5 years, particularly in countries with a high TB incidence, given that the benefits of TB preventive treatment, even without testing, clearly outweigh the risks. For older contacts, TB infection testing may be used to determine eligibility for TB preventive treatment if it is available. Non-availability of TB infection testing and chest X-ray should not pose a barrier to TB preventive treatment. The algorithm caters for situations where these investigations are not available. Let us now look a bit more at the WHO recommendations related to tests for TB infection. This slide is at the courtesy of Dr. Alexei Korobitsin, also on the call today, and it shows the history of the WHO recommendations to this extent. In 2011, WHO issued recommendations on the use of IGRAs for the diagnosis of TB infection, including the technologies listed on this slide. In 2018, WHO has updated the recommendations, stipulating that both TST and/or IGRA can be used for TB infection. And in 2021, the WHO recommendations were extended for the below technologies: the Beijing one-type TB IGRA, the Qiagen Quantiferon TB Gold Plus. And then in 2022, WHO has convened a guideline development group and is planning now to issue further recommendations on the use of TB skin tests for the diagnosis of TB infection, including the CTB of the Serum Institute of India, the Diakin test, and the CTST test. A rapid communication was issued this April on the outcome of the guideline development group. TB skin test is a class and is defined as skin test for detection of TB infection that use tuberculosis specific antigens, ESA-T6 and CFP10. As indicated on the previous slide, the following technologies were included in the evaluation by the guideline development group: the CTB, the CTST, and the DIA skin test. The objectives of the guideline development group were to assess the available data on TB skin test related to patient-important outcomes, including diagnostic accuracy, safety, concordance, and economic and qualitative evidence in comparison to TST and IGRA. So this slide lists the key findings, and the key findings were, in summary, TB skin tests were found to be accurate for detection of TB infection compared to TST and IGRA. The pooled sensitivity and specificity for TB infection detection were 76% and 98% respectively. The difference in specificity between TB skin test and TST among those who were BCG vaccinated was 67.4% and was higher for the class of TB skin tests. However, the difference in specificity between the TB skin test and the IGRA among those who were BCG vaccinated was only 9.7% and lower for the TB skin test, although the confidence intervals overlapped. Agreement with TST in people without TB disease was nearly 60%, and in people with TB disease, it was 88%. Agreement with IGRA in people without TB disease was 89%, and in people with TB disease was nearly 86%. The TB skin test safety profile appeared similar to that of TST, and the TB skin tests were found to be cost-effective. Lastly, they were found to be acceptable and feasible compared to TST. The upcoming recommendations will be relevant for children of all ages because the evidence that was assessed by the WHO Guideline Development Group included children as well. So it's my pleasure now to hand over to my colleague, Dr. Kerri Viney. She's the team lead of the comorbidities TB, HIV, and vulnerable populations unit or team in the vulnerable populations, communities, and comorbidities unit of the WHO Global Tuberculosis Program. And she will take you to the various options for TB preventive treatment to prevent drug-susceptible TB. Kerri, the floor is yours.
Thank you very much, Annemieke, and I hope you can just confirm that you can hear me very well, Elmira. I can see you nodding. So,
Kerri, can we just do something? Dear
yes.
Annemieke, can you please restart sharing of your screen, because someone from participants has painted on the screen.
I saw that, yeah.
Yeah, so I think we need to restart the sharing if possible.
Thank you.
You just stop sharing and then launch it again, please, Annemieke. Mm-hmm. Thank you. Perfect.
Sorry. Can you see still my old slide, no?
We can see K findings, yes.
Yes, I'm trying to move, but it doesn't seem to move anymore. Let me try here. Yes. It should be fine. Kerri, can you see it?
Yes, I can. Yeah. It went to the next one. It's no problem. Well, firstly, thank you for the invitation to speak here at this Medical Consilium meeting. And thank you, Annemieke, for the very kind introduction. It's wonderful to be here and be talking to you about the updated guidelines and also the operational handbook on the management of TB in children and adolescents. So I'm going to continue the presentation now and talk about tuberculosis preventive treatment, as well as the diagnostic considerations to conclude the session today, and then we'll have time for questions. So just picking up on Annemiek's presentation, in terms of the options for tuberculosis preventive treatment, or TPT, to prevent drug-susceptible TB, as you can see on the slide, the following options for TPT are strongly recommended for use in children and adolescents. So they include 6 or 9 months of daily isoniazid, which is recommended for all ages, or 3 months of weekly isoniazid plus rifampicin, so that's 3-HP, which is recommended for children and adolescents aged 2 years and above, or 3 months of daily isoniazid plus rifampicin, which is also recommended in all ages. Now for 1-HP, so 1 month of daily isoniazid plus rifampicin, that is recommended for adolescents aged 13 years and above, and then 4 months of rifampicin are also alternative options. And the choice really of the regimen for TPT does depend on the availability of the appropriate formulations. We do know that rifampicin is not available in all countries, as well as considerations for age, safety, drug-drug interactions, and adherence. I think it's important to remember that there are some age cutoffs currently in the WHO recommendations for TPT. So as you can see on the bottom of the slide there, 3-HP is currently recommended for children and adolescents aged 2 years and above, whereas 1-HP is recommended for children, or adolescents rather, aged 13 years and above. There is, of course, ongoing studies to look at the use of rifampicin, in particular in younger age groups, including in infants. We're monitoring those studies quite carefully, and of course, WHO will be ready to assess that evidence when it is available. Now, I think the other thing that is probably just important to note is that the rifampicin and rifampicin containing regimens should be prescribed in caution with children and adolescents living with HIV and on ART because of potential drug-drug interactions. And there is a very useful drug-drug interaction checker provided by the University of Liverpool. Next slide, please, Annemieke. Now, I'll just speak while the next slide's coming. Now, in the operational handbook, we do have a table which provides information, this table here, which provides information on the preferred regimens for children with and without HIV when being prescribed TPT. So for children below 2 years of age, you can see on the slide here who are HIV negative, the preferred regimen is 3 months of daily isoniazid plus rifampicin. And then for children aged 2 years and above, and who are also below 25 kilograms, again, the preferred regimen is 3 months of isoniazid and rifampicin if the pediatric fixed dose combination is available. And in the operational handbook, we also provide alternative regimens that you can see in the far column if those pediatric FDCs aren't available. Now, for HIV negative children who are above 25 kilograms in body weight, then the recommendation is for 3 months of weekly isoniazid and rifampicin. They can also benefit from a regimen comprised of 3 months of isoniazid and rifampicin using the widely available adult fixed dose combinations if they're available. Adolescents above 13 years can be given the 1 month isoniazid rifampicin TPT regimen as well. So as I said in the previous slide, that is recommended only for adolescents aged 13 years and above. Then for children living with HIV, the preferred regimen for prevention is 6 months of isoniazid, preferably using the dispersible tablets, 3 months of isoniazid and rifampicin can be given to children on efavirenz-based ART, and 3-HP is also an option for older children on efavirenz-based ART who are able to swallow whole tablets. And then finally, for adolescents living with HIV, the preferred regimen is 3-HP if they're on the ART regimens as shown on the screen. And then an alternative regimen is either 1-HP or 6 months of isoniazid. There are a number of considerations, of course, for all of these regimens, and they are outlined in the operational handbook, which also contains dosing instructions, as well as guidance on adherence and how to manage interruptions to TPT, as well as criteria for TPT completion. So that is all included in the operational handbook. Now, I think one thing that this next slide, please, Annemieke. I think one thing that this group in particular might be interested in is TPT or preventive treatment for high-risk household contacts of patients who have multi-drug-resistant or rifampicin-resistant TB. And WHO does have a recommendation for this group. And so as you can see there on the screen, the recommendation is that household contacts of people with multi-drug-resistant TB or isoniazid resistance are at higher risk of TB infection. However, there is the same risk of progression to TB disease as contacts of people with drug-susceptible TB. Now, the conditional recommendation that WHO has issued for TPT for contacts exposed to multi-drug-resistant TB does consider the intensity of exposure, that the source patient is confirmed and that their DST is known, as well as having confirmation of TB infection through TST or IGRA. The suggestion on the drug choice in the WHO recommendation is 6 months of daily levofloxacin. Of course, if the source case is resistant to levofloxacin, that would need to be reconsidered. And in children who are contacts of someone with drug-resistant TB, we do recommend that the pediatric formulation is used. So there is a 100 milligram dispersible tablet of levofloxacin, and that could be used. Now, in the operational handbook on TPT, you can see additional information about this recommendation, but it does say that it can be used, 6 months of levofloxacin can be used with or without other medicines. So for example, ethambutol or ethionamide. There should be clinical follow-up of these children for 2 years, and there should be very active evaluation for the signs and symptoms suggestive of TB. So very active evaluation of a child who might have presumptive TB in this case. Then for children who are contacts of someone with rifampicin-resistant TB, it's the same recommendation as multi-drug-resistant TB, obviously. If the source case is susceptible to isoniazid, 6 to 9 months of isoniazid may be used. And for other contacts, for 4 months of rifampicin may be an option, but there is very little evidence. So these are discussed in the TPT operational handbook. Now, there are studies that are ongoing on regimens to be used as preventive treatment for children and adults, actually, who are contacts of someone with multi-drug-resistant TB, and we are monitoring those studies quite closely, and they will be assessed at some point in the future to further inform new TPT guidance. So you can see on the screen here some of those studies. So there's the TB CHAMP study, which is a study in younger children aged under 5. And that is looking at levofloxacin versus placebo, given daily for 6 months, regardless of TB infection status or HIV status. So that is looking at a levofloxacin-based preventive regimen for children in contact with people with MDR-TB. There is the Phoenix trial, which is also looking at preventive treatment for MDR-TB. That is using delaminid versus a standard dose of isoniazid daily for 6 weeks. And again, that is in young children aged under 5 who are TST or IGRA positive, and then in children greater than 5 in 11 countries. And then finally, there is the VQUIN study, which is looking at 24 weeks of levofloxacin versus placebo. And this is a study in adolescents and adults. So this recommendation on 6 months of daily levofloxacin is the current recommendation. It is recommended that clinicians balance up the benefits versus the risks and does involve close clinical follow-up of those children for 2 years. Next slide. Now, in the operational handbook on the management of TB in children and adolescents, we also provide information on the TPT completion criteria, adherence strategies, and how to manage interruptions to TPT. So the advice in the operational handbook is that children and adolescents on TPT should be reviewed every month for those on a 3-month regimen, or every 2 months for those on a 6-month regimen. They should be monitored for symptoms suggestive of TB disease. Weight should be checked to adjust the TPT dosage. Adverse events should be tracked, as well as treatment adherence and any considerations regarding recording and reporting. The importance of adherence to a TPT regimen should be reinforced at every visit, and any risk factors for poor adherence should be implemented and addressed. And we do provide some strategies in the operational handbook on how to manage when young children may not want to take medicines, including offering TPT with food that might mask the taste, providing a treat when treatment is completed, or how to manage children if there is vomiting. Now, the shorter TPT regimens have been associated with better adherence. So of course, if they can be administered, given all of the considerations that I mentioned earlier, that is probably preferred. And higher treatment completion is based on 80 or 90% of recommended doses taken within 133% of the planned TPT duration. So taken within the planned TPT duration plus a third extra. Next slide, please. Just a little bit aware of the time, so I'll try and now, moving on now to new approaches to the diagnosis of TB in children and adolescents. I'm going to talk specifically about some of the new recommendations in the guidelines on the management of TB in children and adolescents, as well as some of the existing recommendations that we have in the diagnostics guideline and the operational handbook. So firstly, this is a new recommendation on the use of Expert Ultra. So for the guideline development group that we held in 2021, we specifically looked at the use of gastric aspirate and stool using Expert Ultra in children with signs and symptoms of pulmonary TB. The resulting recommendation is the one that you see here on the screen. So in children with signs and symptoms of pulmonary TB, Expert Ultra should be used as the initial diagnostic test for TB and for the detection of rifampicin resistance on sputum, nasopharyngeal aspirate, gastric aspirate, or stool, rather than smear microscopy and culture and phenotypic DST. So this is a strong recommendation. And you can see now that we have a wide range of specimens, so sputum, nasopharyngeal aspirate, gastric aspirate, and stool for the detection of pulmonary TB. And of course, we have the same recommendations for Expert NTB-REV. Now, although there was no evidence at the time on the accuracy of the detection of rifampicin resistance, the previous recommendation on the use of Expert Ultra for the detection of rifampicin resistance in sputum samples and nasopharyngeal aspirate was extrapolated to stool and gastric aspirate in this particular instance. And there are some considerations in both the guidelines and the operational handbook regarding the acceptability and feasibility of implementing both stool and gastric aspirate specimens. And of course, they will need to be taken into account. Now, just for those of you who were interested, when we did look at this particular question for gastric aspirate, the sensitivity against a microbiological reference standard was 64%. the specificity was 95%, and then for stool, the sensitivity was 53%, and the specificity 98%. And that's all documented in the annexes in the guidelines if you're interested in those details. Next slide, please, Annemieke. Now, in terms of our broader recommendations from WHO on expert MTB-RIF and expert ultra as the initial test to diagnose pulmonary TB and rifampicin resistance in children, these are the current recommendations. So these are from module 3 of our WHO consolidated guidelines on tuberculosis. So you can see here that the current recommendations are that in children with signs and symptoms of pulmonary TB, expert MTB-RIF should be used as the initial diagnostic test for TB and also for the detection of rifampicin resistance. And as mentioned on the previous slide, we have those 4 specimens there that can be used. So sputum, gastric aspirate, nasopharyngeal aspirate, and stool. And this is rather than sputum smear microscopy and culture and phenotypic DST. Similarly, we have the same recommendation for the expert ultra assay, which also should be used as the initial diagnostic test for TB and the detection of rifampicin resistance in the same set of 4 specimens, rather than smear microscopy, culture, and phenotypic DST. And maybe at this point, it's important to note that stool is considered as a specimen used for the diagnosis of pulmonary TB because children are swallowing their sputum and then obviously excreting it in stool. Next slide, please, Annemieke. Then if we think about the WHO recommendations on extrapulmonary TB, and of course this is quite important for children and adolescents. So we have a number of recommendations, similar recommendations on expert MTB-RIF and expert ultra as the initial tests to diagnose extrapulmonary TB and also rifampicin resistance in those specimens. So those recommendations include in adults and children with signs and symptoms of TB meningitis, that expert MTB-RIF or ultra should be used in CSF or cerebrospinal fluid as the initial diagnostic test. And again, it is rather than sputum smear microscopy culture. For those who have signs and symptoms of extrapulmonary TB, expert MTB-RIF may be used in lymph node aspirate, a lymph node biopsy, pleural fluid, peritoneal fluid, pericardial fluid, or synovial fluid, or a urine specimen as the initial diagnostic test, rather than sputum smear microscopy and culture. And then similarly for expert ultra, that may be used in lymph needle aspirate and lymph needle biopsy. Now, for children with signs and symptoms of extrapulmonary TB, expert MTB-RIF or ultra should be used for the detection of rifampicin resistance rather than culture and phenotypic DST. And then finally, there's a WHO recommendation on children and adults with signs and symptoms of disseminated TB who are HIV positive, that expert MTB-RIF may in fact be used in blood as the initial diagnostic test for disseminated TB. And I should mention for each of these recommendations, you can see the little table on the right. So that has the strength of the recommendation, as well as the certainty of the evidence for those particular recommendations. And of course, this is all documented in the guidelines. Next slide, please, Annemieke. Then going back to the guidelines on the management of TB in children and adolescents, there is also a new recommendation on the use of integrated treatment decision algorithms in children. I can't see the next slide, but maybe it's coming. So this, there we go, great, thank you. So this recommendation states that in children with presumptive pulmonary TB who are attending healthcare facilities, integrated treatment decision algorithms may be used to diagnose pulmonary TB. I will show one of the decision algorithms shortly, but these incorporate a rapid diagnostic test as well as chest radiography features, as well as signs and symptoms of TB. So for this recommendation, it's an interim and a conditional recommendation. It is valid for 2 years, after which new evidence will need to be reviewed. And an important remark, for this recommendation is that bacteriological confirmation should be sought whenever possible, in line with the current recommendations on rapid diagnostic tests, which we just went through in the previous 2 slides. Now, next slide, please. Just a bit of background on this recommendation on treatment decision algorithms. So the recommendation itself was more of a general recommendation that treatment decision algorithms should be used to diagnose pulmonary TB, particularly in children. After the guideline development group meeting that we held in May-June 2021, 2 algorithms were developed after this meeting by evidence reviewers in consultation with a subgroup of the guideline development group. And in fact, that means that in the operational handbook, we now have 2 specific algorithms that can be used. There is algorithm A for settings which have access to chest X-ray, and then algorithm B for settings where chest X-ray is not available. These algorithms are mainly aimed at the primary healthcare level to build confidence and capacity in clinicians to make a decision to start TB treatment. Now, in terms of the methodology to develop these algorithms, prediction modelling was used based on an individual patient database, which contained about 5,000 records. A sensitivity cutoff was pre-specified for a particular section of the algorithm, which was 85%. And then the corresponding specificity resulted in 37% for algorithm A and 30% for algorithm B. There are additional steps in the algorithm, and I'll show you that shortly. So there's a triage step and a risk assessment step, and treatment for alternative diagnoses if the child is actually at low risk of having TB, as well as bacteriological testing to overall improve the diagnostic accuracy. Now, there are detailed guidance and examples in the operational handbook on the management of TB in children and adolescents with a printable job aid, so that can be taken out in Annex 5. So this is just an example of the treatment decision algorithm. As mentioned, there are 2 algorithms, algorithm A and algorithm B, for settings with and without access to chest radiography. Both algorithms are, of course, included in the operational handbook. So the main characteristics of the algorithms are the inclusion of a triage step to either stabilize or transfer a child who is in need of very urgent medical care. This is then followed by a step to assess the risk for rapid disease progression, which determines the timing of the next steps in the algorithm. Children who are below 2 years of age or who are living with HIV or have severe acute malnutrition are regarded as high risk, and they continue with the next steps in the algorithm immediately. But then children who are not regarded as high risk are first treated for the most likely non-TB related conditions. So that might be pneumonia, asthma, malaria, and they only go on to the next step in the algorithm if there is no improvement after 1 to 2 weeks. The next step in the algorithm is to use molecular WHO recommended diagnostic tests on the pediatric specimens, and also LF-LAN if the child is living with HIV. Next slide, please. Now, this slide shows the bottom part of algorithm A. So I've just shown the algorithm in 2 sections. The previous slide was the top part of the algorithm, but it does continue. This yellow block that you can see in the middle provides scores for clinical signs and symptoms, as well as chest radiography features. So those chest X-ray features include cavitation, enlarged lymph nodes, opacities, a miliary pattern, and pleural effusion. So if the total score of these signs and symptoms and chest X-ray features in that yellow box that you can see there, if that total score is more than 10, the child should be started on TB treatment. Now, I think it's important to remember that a child can have a chest X-ray at any point in the evaluation, And should the score based on the signs and symptoms already be more than 10, treatment can be started while awaiting the chest X-ray result. Chest X-ray is highlighted here as an important tool to determine disease severity, which is one of the two other assessments that a child with a decision to start treatment should undergo. And the other assessment is for risk factors for drug-resistant TB. And as mentioned, the handbook does contain detailed guidance and examples of the scoring, as well as the printable job aid that I mentioned previously. One other thing that I think is important to note is that following an expert consultation on the classification of intrathoracic TB disease in children, intrathoracic lymph node TB is now classified as pulmonary TB and is no longer classified as extrathoracic TB. Be published in some global guidance on TB surveillance shortly. Okay. So finally, I'd just like, you can go to the last one, Annemieke, it's fine, because I think we're just a little bit over time. Finally, I would just like to, I think you can go to the next one. Yeah, thank you, Annemieke. Yeah. So finally, I would just like to conclude and acknowledge my colleagues who are listed here on the screen. Teresa Kasayeva, our director, Farai Mavunga, our unit head, particularly Sabina Verkeil, who is on the line. She is our medical officer specializing in TB in children and adolescents. Tiziana Massini, who is a consultant. Nazir Ismail is our team lead for diagnostics, Alexei Korobitsyn, our medical officer for diagnostics, and I think both of them are on the line for any diagnostic related questions, and then other colleagues within the Global TB program. I'd also like to acknowledge all of the experts who contributed to both the guidelines and the handbook, including the guideline development group, the partners who were involved, the external review group, and members of the Child and Adolescent TB Working Group. And I think there are also people on the line who contributed to both the guidelines and the handbook, and I would like to acknowledge their contribution to this work. And we've gone a few minutes over time, I apologize, but I hope there's still plenty of time for questions. Any questions that we can't answer, as Elmira mentioned, we're very happy to follow up in written form afterwards. And as mentioned, we do have Sabina, Alexei and Nazir on the line for any specific questions as well. So thank you very much, and thank you to Annemieke as well. Thank you.
Огромное спасибо, Kerri, Annemieke, за...
Thank you, Katie and Annemieke, for such a splendid presentation of comprehensive information, so many new developments. I'm sure there will be questions from the audience. So far, there are no questions in the chat. Dear colleagues, if you have any questions, please raise your hands. Unmute yourself and ask your question. I don't see any raised hands. While we're waiting for the audience to ask questions, I would ask my own question. It was very interesting to see the algorithm, the clinical decision-making algorithm on treatment initiation in children and adolescents. It's really important, especially taking into account that the fact that in many countries TB in children is underdiagnosed, and they strive to reach bacteriologic confirmations, and they are wary of relying on clinical diagnosis. And therefore, would like to clarify the following. You've said that this algorithm is recommended for countries with high burden of TB, 100 per 100,000 population. So what do you consider to be a high burden? Is it 100 per 100,000? And it's my suggestion. Could you please clarify what countries belong in the group of countries with high burden where this algorithm should be used? And the next question, you've noticed or mentioned that speaking about the TB epidemiology, globally, about 10% of all TB cases are TB cases in children. In Europe, it is about 9%, but unfortunately, in our European region, there are countries with low incidence, for example, up to 20 per 100,000, and less than 1% among children. So the incidence is low, but the underdiagnosis is very high. Can we use this algorithm in such countries with a low to moderate incidence, but with high underdiagnosis? Could you please unmute yourself?
Yes, so I apologize. Did you want me to take the question, Annemieke?
Yes, please go ahead.
Yeah, sure. Okay. Thank you very much for the question. So maybe just to take a little step back in terms of high burden countries, WHO does have a predefined list, which you might be aware of, which includes high burden TB countries, high burden TB HIV countries, as well as high burden MDR TB countries. So usually we go by that list to determine who is a high TB burden country. But of course, there are some other specific cutoffs for some other WHO recommendations, which does include 100 per 100,000, and often that's used in the screening recommendations. Now, for this recommendation in particular on treatment decision algorithms, as mentioned, it is designed primarily for use at the primary healthcare level to get more children into sort of a diagnostic algorithm and to make sure that they're diagnosed, because as Annemieke explained, the biggest gap really is in detection or diagnosis. There is a smaller gap between diagnosis and treatment, and that is a much smaller gap. But the biggest gap is really finding children, and diagnosing them with TB. So this algorithm is not specifically just for countries with a TB burden greater than 100 per 100,000, but it is more designed for the primary healthcare level. We will be commissioning we will be coordinating some future research and evaluation on these algorithms, and that may be in multiple settings. But I think these algorithms can be used in other settings. It's not just for the high burden countries, but as mentioned, they are primarily designed for the primary healthcare level, where children may be presenting with signs and symptoms of tuberculosis or presumptive TB. So I hope that answers the question. Annemieke, did you want to add?
Yes.
Or Sabina may want to add?
Yeah, thank you, Kerri. Maybe just to add as well that it's not only to find more children closer to where they live, but also to find them earlier, to avoid sequelae and children going through the different levels of the health system, if at all they have access, and then ending up at tertiary care, where of course there's more access to diagnostic tools. And we know we've been on program reviews in various high burden countries, and we know that countries are looking at scoring systems. And this was an effort to try to see how well these scoring systems are doing. And in the end, the GDG decided that they couldn't recommend one of the existing algorithms, hence the more general recommendation on the use of treatment decision algorithms. And now we have these two newly developed algorithms that need to be externally validated within this 24 months period. But it's really an attempt to find children earlier and find more children, because of the huge case detection gap that countries face. Thank you.
Спасибо большое за детальный ответ.
Thank you very much for such a detailed answer. I'm very glad to hear your comment that this algorithm is usable not only in countries with high burden of tuberculosis, but it is applicable in other countries, in other settings, which is really important to our European region. We have a question in chat. Askar has raised his hand. Perhaps you should go first.
Kerri, Annemieke, for describing and presenting the module. This is the first part of the module, so this is very instrumental. At the same time, right now, as you know, due to the humanitarian crisis as a result of the war in Ukraine, the countries of the WHO European region, specifically in Central and Western Europe, are experiencing the high influx of refugees from Ukraine, and Ukraine is one of the 18 high priority countries of the WHO European region for tuberculosis. But again, the latest incidence is below the 100,000. It's 73 per 100,000 as of the last year. So, and just like for the information, there were some of the questions raised by several member states in Europe, whether to introduce the mandatory or compulsory screening and systematic testing and screening for tuberculosis of the children of preschool and school age among the refugees from Ukraine. So the WHO Europe, together with ECDC, had reviewed the latest evidence, but at the same time concluded that systematic testing for all refugees, specifically for this specific age group, for the refugees from Ukraine, is not recommended. And also, again, this is a very important aspect, but again, this is the recommendation from the based on the evidence that is available from the WHO and ECDC, but each country is sovereign in terms of taking their own decisions. So, but nevertheless, this information note that has been released at the beginning of April, it was just a month before the release of the new module. So just like wanted to say that there is no contradiction in what is recommended in module 5, and that these universal testing for tuberculosis infection and screening for tuberculosis disease can be done in a certain population group at high risk for developing tuberculosis, but should not be compulsory, because it's also associated with stigma and discrimination. Thank you.
Thank you very much, Askar, for mentioning that, and maybe also to reiterate that in particular young children are not transmitting TB. So it's more if they are a contact or living in an environment or have close contact with a person with pulmonary TB, that they need to be evaluated. And if they are already on treatment, that treatment should of course continue. And if they're at risk of TB infection, then it would be good if they could receive TB preventive treatment. And we are well aware of the challenges in Europe with access to child-friendly formulations, but I know you and other organizations are looking at how to guarantee that treatment can be continued for these groups. Thank you.
Спасибо большое, Аскар, за важную информацию. Я озвучу.
Thank you, Askar, for such important information. I will ask the next question.
Сначала, конечно же, слова благодарности за прекрасную презентацию.
First of all, I would like to thank you for an excellent presentation. You presented 5 regimens for preventive treatment of tuberculosis. What is the percentage for the usage of each regimen you can expect when you plan a preventive treatment? Apparently, this question is asked by the person who is dealing with planning the procurement of TB drugs.
Thank you very much for that question. We do not have these percentages. However, WHO strongly recommends shorter regimens. So because they are proven to enhance adherence and treatment completion, and they're actually more patient-friendly, family-friendly. So shorter regimens according to the age groups and according to whether or not the child is on ARVs should be preferred. But unfortunately, we can't provide such percentages. I don't know, Kerri, would you like to add to that?
No, I don't have much to add unless Askar and colleagues I can see Sabina's got her hand raised as well. So maybe I could hand to Sabina or Askar. There may be some local information in Euro that's available on that, but we don't have that at the global level. Thank you.
Thanks very much. Thanks for the opportunity and the presentations and all the questions. I just wanted to say in terms of the choice of TPT regimens, it will really depend on the local situation in the countries. Of course, globally, we encourage countries to use 3HR in HIV negative children up to 25 kilos because of the availability of the child-friendly formulations. But of course, we know that in Euro that is a problem. So in the European region, it may make more sense to use other regimens. And for the current cycle of data collection for the global TB report, we've actually requested countries to provide a bit more detail on whether the shorter regimens, the rifampicin-based regimens, are being used, and to get a little bit of a better idea of usage of the various regimens. So it's broken down by 3HR, 3HP, and 1HP. So that's going to be also providing a little bit of a better insight in the use of these regimens. Yeah, I just wanted to add that. Thank you.
Thank you very much, Sabine. And maybe one more thing is that the 3HP regimen is, of course, a very promising regimen, but it might mean a high pill burden. So if the child is unable to swallow pills, that may not be the most appropriate option at this point in time. So, and of course, dispersible tablets should be given priority when you build your regimen. Thank you.
And maybe if I could just add those data points that Sabina mentioned, they would eventually feed into our global TB reporting. So I think people on the call are aware that, we publish the global TB report around October every year. We have moved to a slightly different format of the report, so it's mostly online. So those data points that Sabina mentioned would be available. We're going through quite an extensive process of checking the data at the moment. So they would be available, not currently, but later in the year. Yeah, just to add that. Thanks.
I also wanted to say is that we will have the next part of this presentation of this module on the 24th of June, and we were considering that to provide an update from our colleagues from the Stop TB Partnership GDF on the access to the pediatric formulations, and please bear with us on this. Thank you.
Спасибо большое за интересную дискуссию.
Thank you very much for an interesting discussion, and I would like to ask the next question. In case of TB preventive treatment in children requiring immunosuppressive therapy, what is the most optimum time for treatment initiation? Before the start of treatment or simultaneously? And here we mean anti-TNF drugs.
Just to respond to this question, I would have to double check the exact timing. I'm not sure if Sabina or Annemieke might be able to comment. But I think this is really always a matter of balancing the risks and the harms of these choices. So I would have to double check the exact timing. So I'd be happy to revert on that question with a written response, although Annemieke or Sabina might want to comment on that one. But I think it really is a matter of balancing the benefits and the harms potentially of that. Thanks.
Yeah, maybe just to add, thanks, Kerri. In the TPT guidelines, patients on TNF are a risk group. So, so they are sort of a priority group for receiving TPT by the virtue of having immunosuppressive actions. So, if they are infected with TB, they have a high risk of progressing to TB disease. I am not fully aware of any potential drug-drug interactions. So, for that, I think we can check with our colleagues in the prevention team and let you know.
Elmira, I have nothing to add, but if we find more information, we will definitely share with you.
Спасибо большое. Я просто поделюсь опытом.
Thank you very much. I can share the experience from practice. Actually, this is a very good question. In the past, when we used 6 or 9 months treatment regimens for preventive treatment, we usually started treatment preventive treatment first, and then 3 months after, we started immunosuppressive therapy. But now, when we started using shorter treatment regimens, the question is still relevant, when to start this kind of therapy. So we would like to discuss it with all the members of this webinar. I see that we have one more question. Or rather a request for counseling the patient, and unfortunately we do not have much time for that. We will not be able to provide comprehensive consultation, but Natalia, we will try to support you with advice. And I would like to say that should you have any questions related to clinical cases, related to preventive or tuberculosis, including drug-resistant tuberculosis, you can always apply to the Virtual Medical Consilium. And we already told you how to do so. In our chat, you have the link with the instructions on how to apply to the Virtual Medical Consilium. So you can consider that as an option when you need to seek for an advice. And one more brief question, probably we have enough time to try to answer it. Do you think that computer tomography of chest is good for the work with children, especially when we work with smaller forms of tuberculosis?
We don't have any guidance on CT specifically in our WHO guidance. We've included radiography, but this question does come up. I'm not sure if Sabina might want to respond based on her clinical experience, but we have asked clinicians this question. Sabina, I remember James Seddon had a response to this question that was asked previously. So I think yeah, we as WHO, we don't have any guidance on CT. I know some clinicians are using it, and this does come up in some clinical discussions. And there seems to be varied opinions on its utility, depending on, you know, the other clinical findings, the chest radiography findings, etc. But Sabina might want to comment on this, but this question does come up, and I know it's a topic of discussion among clinicians. Sabina, did you have anything to add on CT?
Yeah, well, not really, but I think it really depends on the local situation and local guidance. And if CT is readily available, why not use it? And of course, our guidance often has to cover all situations globally. But if you're in a sort of slightly higher income setting with these resources available and these imaging techniques available, it may be helpful because often on a plain chest X-ray you do not see the details of, for example, lesions in the lungs. You may only see the lymphadenopathy and actually cannot find the primary focus, which you may be able to see on a CT scan. So if it's available, it may be a tool, a useful additional tool to make a diagnosis. Thank you.
Спасибо большое. И если позволите, последний вопрос.
Thank you very much. And if I may, I would like to ask the final question that we hear quite often from the countries. It is related to children living with HIV. We realize that HIV is a risk factor that will be their lifelong risk factor. We say that children with HIV are supposed to receive preventive treatment of tuberculosis, but do we mean single course, or we need to repeat it? And if so, how frequently?
Kerri, go ahead.
Yes, I can. Yes, I will have to check the frequency unless Sabina or Annemieke are immediately aware, but certainly at each presentation to the health system, they should be assessed for presumptive TB. So administered TPT and then at each subsequent visit assessed. But on repeat courses of TPT, I think there is some advice in our TPT handbook, but I would have to check on the specifics. But Sabina or Annemieke may want to add. Thanks.
Yeah, I think there's also a recommendation on which is conditional, which is on a longer duration of INH for 36 months in people living with HIV. That recommendation is there, but it's actually not widely implemented. But it is something that I think was based on a large trial which showed protective, longer-term protective effect. And as Kerri says, we would have to just look up the issue around repeating, but I think it's not currently recommended. Like with every exposure to repeat, but it will really also depend on the local situation. And that said, the protective effect of TPT varies a bit, but there are studies that show quite a long duration of the protective effect. So I think that's also one of the reasons why it's not so clear to what would be the frequency or what would be the time frame to repeat a course of TPT. And especially now we have much shorter TPT regimens. So it may be a question that needs to be answered in an upcoming guideline development process. Thanks.
Sabina, if I can just add, because I've just looked up our TPT handbook, and what it says currently is that there's no evidence to date on the utility of repeated courses of TPT. But of course, a repeat course should be considered if someone has been a household contact or something like that. So this is really an area for future research as well. So there's limited data, it appears, but some guidance for repeat courses if the child was, a household contact, again, of someone, so if they had an initial course of TPT and then maybe 2 or 3 years later, they're in contact with someone, there is some guidance in the operational handbook on TB preventive treatment, but it also says that there's a need for further research on the utility of repeated TPT courses. So I hope that answers the question, but this is in the operational handbook on tuberculosis preventive treatment, page 67. Thanks.
Спасибо огромное. Мы подошли к...
Thank you very much. We have come to the end of our webinar. Immense thanks to our speakers for interesting information, for such a productive discussion. And I would like to remind the audience that on the 24th of June, we will continue our webinar dedicated to the TB in children and adolescents. And on June 24, we will speak about the diagnosis and treatment of active TB. I would like to thank once again everyone for attention, and I would like to pass the mic to Dr. Yedilbayev, team lead of the joint unit on infectious diseases, to say some final words.
Dear colleagues, dear participants, and thank you very much for joining today the 16th webinar of the Virtual Medical Consilium of the WHO European region. And we definitely hope that these webinars you find very useful and interesting for your daily practice. And again, today, participation was really tremendous. We had 215 participants of this webinar, and it's really a very good achievement. And we observe this from each webinar to another. And again, we will be happy to highlight very interesting and key topics for your to support your work, because you are there in the field and in the front line working in the treating tuberculosis. So there are many questions that we have. We have some of them remain unanswered. So would you please write your emails to the mSTR Consilium, and we will refer them to our dear speakers, and hopefully, because we will have the second webinar, it will be answered during that time as well. So again, we are having our next webinar on the same topic for the second part of the module on the 24th of June. So please bear with us. And again, thank you very much for all your great work, and thank you. Good luck.
Thank you, and it was a pleasure.
До свидания, дорогие коллеги.
Thank you very much. Yes, pleasure. Thank you.
Thank you.